The value-based insurance design model seems to be a solid and practical approach to aligning patients' out-of-pocket costs with the value of health services they receive. What kind of overall feedback have you heard about value-based insurance design from your clinical colleagues?
So I think the feedback as a whole has been overwhelmingly positive. There's been a couple of general themes. So one is the idea that we can take what is a very sensible clinical policy and test it in a real-world setting using typical methods that we would use to test new drugs, for example. So we use a rigorous clinical trial design with some modifications, since this really was a policy intervention, and tested it. And so the feedback is immediately one of face validity. We understand this research method, it's rigorous, and therefore we believe the results. And so that, from that perspective, it's been universally positive. The other set of feedback really relates to what I was talking about a moment ago, which is that despite the fact that we gave away drugs for free, adherence is extremely poor. And so it's highlighted, I think, for my clinical colleagues, just how big of a problem this is. We spend our time as clinicians thinking about appropriate care for patients, and as internists, we prescribe medications routinely, but we seldom think about then what happens downstream. We think about whether their blood pressure improved, or their cholesterol levels improved, or their sugar control got better, but we seldom think about, well, were patients actually adherent to their medications? And I think this body of research and some of the other work that we do highlights the idea that our job isn't done once we've made the decision to prescribe. Our job really is an ongoing effort to help patients adhere to their therapies in the long term.